evaluation of a novel CRISPR-Cas12a based diagnostic tool for fungal endophthalmitis. So we have no financial disclosures. So fungal diseases, despite causing 1.5 million deaths annually and affecting more than a billion people every year, remain a pernicious neglect. This is best exemplified by the high rate of misdiagnosis reported with fungal infections across various organ systems. Hence, there's a huge, urgent, and unmet need to improve fungal diagnostics. So, fungal endophthalmitis is also a similar scenario. Extensive culture positivity rate has been reported with endophthalmitis, with only 20% being culture positive and 80% being culture negative. Among these 20% culture positive, 11 to 22% are fungal. But recent NGS data from India suggests that of these 80%, 65% are actually fungal, and we may be only seeing the tip of the iceberg as far as fungal endophthalmitis is concerned. So the purpose of our study was to develop a rapid, accurate, cost-effective test to diagnose fungal endophthalmitis using CRISPR, which we have termed as RIDMIC, which stands for Rapid Identification of Mycosis using CRISPR. So before I begin, a brief introduction into CRISPR. In one line, they are the antibody equivalents of prokaryotes. So when we as eukaryotes come in contact with a virus, we recognize their proteins and synthesize specific antibodies against them, which we harnessed in creating vaccines. However, given the primitive state of the prokaryote immune system, they rather recognize foreign nucleotide sequences and engineer Cas enzymes to recognize and cleave these sequences. So we very recently started harnessing this ultra specificity of bacterial Cas for genome editing and diagnosis. So this step, there are two main components of this assay. The first is isothermal amplification, which amplifies the target fungal DNA if present, followed by the CRISPR reaction, which in the presence of the amplified target DNA cleaves the fluorescent reporter. So because our aim was to both make it as a point of care test, which would help in antimicrobial therapy within the OR, and also as a replacement or an alternative to PCR in tertiary facilities to predict fungal load, we included two readouts. One is the binary qualitative readout, which gives an easy yes or no interpretation, and the other is a quantitative readout, which gives us the ability to predict fungal load. The first step was to test the specificity of the assay. So we tested against 9 fungal DNA from patient isolates. As you can see here, a positive test was seen with all fungal DNA, but not with bacterial or human DNA. The corresponding spike was also seen in the spectrophotometer readings. So the next step was to test the analytical sensitivity of this assay. The analytical sensitivity of this assay was around 13 to 16 genome copies, which is similar or even better than pan-fungal PCR. So this shows a workflow of the assay. The first step is, once the intraocular fluid is collected from the eye, it is subjected to recombinase polymerase amplification, which happens for 37 degrees at 30 minutes, followed by the CRISPR reaction, which also happens at 37 degrees Celsius for 10 minutes. So it's important to remember that pipetting is the only expertise which is needed, and the heat block is the only equipment which is needed. After this, the result can be visually interpreted. So now, after the development phase, we proceeded to test the clinical validity of this assay. 86 intraocular samples, including 62 vitreous and 24 aqueous humor samples from 75 patients with clinically presumed infective endophthalmitis were included. So conventional institutional practice was that these fluids were subjected to direct microscopy and fungal culture. In addition to this, we also did pan-fungal PCR and the RIDMIC assay. So bacterial culture positivity was in 20%. Fungus was seen by culture only in one sample, while pan-fungal dPCR detected fungus in 14 and RIDMIC in 18 patients. So the concordance between the 280 samples are concordant between RIDMIC and PCR. In comparison to PCR, the sensitivity of RIDMIC was 92.86% and the specificity was 93.06%. I think I'll show three interesting cases which highlight the how RIDMIC is better than PCR. So this is a 90-year-old male with endogenous endophthalmitis. The patient came with hand movements. Clinical suspicion was bacterial. However, pan-fungal PCR was positive for fungus. RIDMIC was negative. But the culture eventually grew gram-positive bacteria, and the patient did well with intravitreal antibiotic. Here, off-target amplification is a big problem with PCR. Here, the specificity of PCR is driven by the two primers, but in RIDMIC, there are ideally two checkpoints. In addition to the primers, there's also the specificity of the guide RNA. So, less off-target amplification makes RIDMIC more specific than PCR. The next is, this is a 32-year-old male with injury with plant extract, clinically fungus but was treated with antifungal, after which he developed intraocular inflammation. Culture was negative, rhythmic was positive, PCR also was positive. Eventually, the patient grew to unidentified adventitious fungi. So again, prior antimicrobial therapy influences the results of culture. Nucleic acid detection strategies like PCR and rhythmic are advantageous in these scenarios. This is another very interesting case. 1 week after post PPV, the patient develops endophthalmitis. Clinically, because it's acute, is considered bacterial. Pan-fungal PCR was negative. Rhythmic, however, was positive. And this patient is also important to remember. PCR is susceptible to intrinsic inhibitors present in occus and vitreous, while rhythmic is not, the chemistry being different. So again, this is the clinching evidence we show. We did NGS on these discordant samples, and then there's 100% concordance between rhythmic and the NGS data. So to conclude, this is the first CRISPR-based system for the diagnosis of fungal infections in any organ system, first for the diagnosis of any ophthalmic condition, produces an easy-to-read binary readout, and its sensitivity and specificity is better than PCR. Thank you.
Thank you, Dr. Siddharth. I had one question. What is the pricing of CRISPR compared to PCR?
So this is actually 1/3 the cost, madam.
Okay.
So this is at this percent is
And
around
what
500
is
rupees.
what is the turnaround time?
45 minutes, madam.
45.
So is it available in the market?
No, no. This is an assay we developed, madam.
Okay.
It's not.
And I didn't understand the difference between rhythmic and CRISPR. Yeah.
So rhythmic is a term we coined. Rapid identification of mycosis using CRISPR.
Okay. Okay. So that PCR also identifies DNA, and this also identifies DNA.
Only advantages, it is not susceptible to intrinsic inhibitors, which PCR is susceptible to. PCR requires equipment. PCR works at 3 temperatures. Rhythmic works only at 1 temperature, so no equipment is needed. PCR does annealing and heating. With this, we have worked with 50 nanoliters also. So it works, the volume is not a problem. Thank you.